that alludes to, one of the big components maybe as we think about uncertainty, right? There's uncertainty around diagnosis. I think one way we can alleviate uncertainty is to try and instill this idea of certainty. Patients want certainty. They want to know we have a plan. And so how do we integrate knowing what we're doing with being open to throw treatment options to chance, i.e. how do we take patients who have a new certainty disrupting diagnosis and tell them what we really think you should do is go on this clinical trial where I can't tell you what treatment you're going to get. Yep. How do we leverage the trust we build early on to help people feel comfortable with additional intentional uncertainty in an already uncertain circumstance? So maybe you run a clinical trial program at UCSF. You sort of thoughts on how we can effectively do this?
Yeah, I mean, it's, you're right. These are very sort of complex topics and complex questions, right? It's, I think early on, even again during the first visit, you kind of introduced the idea that essentially a lot of things here are uncertain, right? There is, even with pretty proven treatments, right? You can't really, really guarantee efficacy, right, or really guarantee what's going to happen. You give kind of the most likely scenario, right? And then of course, there are various other approaches. Of course, I'm curious what other folks do, but in terms of like giving patients what the best case scenario is, what the worst case scenario is, also just like also listening to the patient to hear what they're looking to get from you, right? Because I think it's really the things that you say to different people, I think you tailor to that, right? You don't, some people want really, statistics and really pretty, as objective as you can be and really want, the median life expectancy and things like that. But I find that most people actually don't want that. They want to get a sense of what, the options are, what your optimistic scenario is, and sort of how you can make them better, right? And also that beyond this plan A, there's a plan B and a plan C, right? And so I think that ties in a little bit to how to, or at least how I approach, talking about, even greater uncertainty, like in clinical trials, right? Or randomization in clinical trials, where you're, you yourself don't control what they're going to get, and of course they don't control what they're going to get. And it's important, again, to be, of course, pretty honest about that from the outset, and to describe that clearly, right? And it's still, I find often difficult to actually, to both describe that clearly and for a patient to absorb that you don't, in a randomized trial, you don't truly, it truly is randomized, right? That there is not at least in a way that we influence which way they go, right? And then the trust is based on the fact that, we select trials if they are randomized. Well, we select trials, first of all, because we think that they're a good option, right? That they offer something that is beyond standard of care. And that's why, patients would come to an academic center, right? Or in part why they would come to an academic center. And then in offering those trials, and if you have randomized trials, then whatever you're randomizing against is actually a reasonable option that you would choose if that trial wasn't available, right? And I think that's a very important thing to make clear and also to highlight to the patient.
And are you open lots of trials in
Yeah,
Boston?
we certainly do, but I would reiterate that last point. When you're accepting a trial to open at your center, you're accepting it because you believe in your heart of hearts that regardless of which arm that patient is randomized to, you are giving them the best opportunity for treatment. I usually describe it as best standard of care, what I would give you anyway, or best standard of care plus something else. And I have complete equipoise, or I have that complete faith that regardless of which arm I am randomizing that person to, I am doing the best thing for that person, they are doing the best thing, and if you don't believe that, you can't open the trial. So This is something that I think we do share, and as Vadim said, we share with patients, because that's how we maintain trust and how we help patients make that leap of faith. And it's not the right thing for everybody, but we do owe it to actually all patients to at least offer it, because if we're selectively offering based on some characteristic, who knows what, then we're really doing a disservice to that individual. And we know that there is underrepresentation of various populations, particularly Black and brown individuals and people of lower socioeconomic status, people with lower health literacy. It is important that everybody has access to these opportunities, and if they choose not to participate, that is their educated decision after our conversation. But we should not be, being differentiating based on our own biases or even subconscious thoughts or not thoughts that somebody, that person's just not interested. Well, let's at least talk about it, and to share with them that we believe that either option is going to be good for you.
Yeah. Do you think in the multidisciplinary context, do these trial patients or the approach to a trial patient, does it require something different from sort of the multidisciplinary care?
We bring in the research staff. Definitely, and I think, again, just reiterating what has been said, they're given this huge consent that's like 30 pages long, and also, letting them go home and think about it. And then also, just finding out, because sometimes there can be barriers that are unidentified, such as ride issues or access to the medical center. We're downtown, so there could be parking. So there's all these other concerns or things that could influence a patient's decision. And we want to make sure we identify those early so it doesn't factor in, that we try to level the playing field a little bit. But, patients come with their own biases too. And I've had patients say, I don't want a clinical trial, I don't want to be an experiment. Mm-hmm. And so, we take the time to just review what the trial is, and just like everyone has said, talk about standard of care, that they're getting the standard of care with the potential option of something else. That option of something else is still being studied, just like all our treatments to date that we're offering. We're all part of a clinical trial. And then, just making sure that they are making an educated, well-informed decision. And then I just let them know that I support that decision regardless if they're in a trial or not. Yeah. It's their decision. My role, or the importance of me sitting down with them, is making sure that they have a good understanding and they can kind of talk back to me and say, well, this is what I'm thinking, and I have X, Y, and Z. Can you answer those questions? Or, all that kind of stuff. So I think just making sure, just like everyone has kind of said, not discriminating against patients or making judgments, offering care that is approved by science and research, and not, I guess, impacted by what we perceive as barriers, mm-hmm. without really exploring that with the patient in detail. So
I think it's so key. I don't know if it comes up in your clinic, it certainly comes up in mine. The idea that the patients maybe are worried that if they say no to us, that will negatively impact their care. And so that element of, especially when you're having to discuss a trial on a patient you don't have an established relationship, right? If it's an upfront kind of trial, it may be first or even second visit that you're having to approach these issues. And so that real reassurance that, regardless of the decision they make to being involved or not, that won't adversely affect their care.
I mean, I think I say that explicitly to people, right? I think I try to get that gauge. My first question as they're coming in, let's say it's a second opinion, say something like that. What would have you leave this office today and say that was a successful visit? Like, what are you hoping to get out of this hour? So I think that's helpful. I know what they're looking for. Now that means if they weren't looking for a trial, would I still talk about it? Yes, I do. But I think that helps me understand. And I think that I just say, look, my job is to provide you with a menu. My job is that these are standard of care, these are trial options. To me, I sleep at night knowing, just like Brenda said, that I provided you with the information you needed to make the decision. It really isn't relevant to me what decision you make. A patient has to know that you are going to put together the plan for them, and that you're not viewing them as someone to put in a trial, right? That is the most rapid, terrible way you could decimate trust with a patient in very short order. And so I think they just have to know, and it's hard to cultivate that in the 45 minutes from when you met them to when they're leaving with a trial consent or two. But I think it's really important that they feel that. And they have to feel it. And it's and sometimes, despite your best efforts, and you might think you're a good communicator, you don't feel that you're making that connection. But that's where the next other visits come in, right? Because you can't compress it into 45 minutes all the time.